Well, good morning once again to everyone. I am Marisette Hassan, Program Coordinator for the South Carolina Coalition for the Care for the Seriously Ill, that we affectionately call CSI. We are always doing deep dive work into the serious illness continuum. And every year we have been privileged to put on a virtual symposium, especially starting doing this during the COVID time. It has worked very well for us. So Monday through Friday of this week, we have gathered and we are covering relevant topics related to serious illness care delivery. We are thrilled to have each of you to participate. On Monday, of course, Alexis from the Ralph H. Johnson Veterans Center shared with us about hospice and the eligibility benefits. You absolutely, when the recording is available, and it will be available within the week, you want to hear all of the resources that are available for our veterans in terms of hospice benefits and resources and contact names. You always need to know a resource person that you can call when you have a question. So you definitely want to take a look at the slides. The slides will be available as well as the recording. We will be posting those on our website and we'll make you aware when that happens. In addition, on yesterday, compassion fatigue, how we as the direct care workers and administrative workers, right, in the field, how we can prevent burnout and what we need to do to keep ourselves healthy. It's hard to pour from an empty cup. And so we absolutely need to be doing that as well. And this morning, our great friend, Dr. Tracy Fasolino, is going to join us. I want to share with you just a few things. Tracy is not allowing any grass to grow under her feet during this season of her career. She is a professor and distinguished palliative care leader at Clemson University School of Nursing. I'm not going to hold it against her that she's a Clemson alum and working over there. She's also passionate about rural communities, and because she's lived in Appalachia all of her life, she is absolutely a rising policy leader and rock star for the underserved rural communities. She serves as a mentor to students and those that are looking to explore careers in primary palliative care and specialty palliative care. She has been inducted as a fellow with HPNA, and she's also serves on the board for the Hospice and Palliative Care Nurses Association and Foundation, and she is a Florence Wald champion. As you know, this is Nurses Week, so it's very fitting that we have Tracy sharing with us this week. Lastly, I'd like to say to you that Tracy's also was selected as a 2021 Cambia Sojourn Scholar. So she's got a network of leaders that she's worked with across the United States. And she is going to be living in DC for a year, coming up in September as doing a year-long fellowship that she's been awarded with the Health and Aging Policy. So we're thrilled to have Tracy, also one of our instructors with the CSI group. She serves on our education committee, and she is just an all-around great nurse. I'm telling you what. So Tracy, tell us about what's happening in the legislative policy world. Take it away.
Thank you, Marisette. I tell you, I always get so uncomfortable with those introductions. It's like too much, right? I'm just a good old girl growing up here in Appalachia, and having worked with you all on the CSI team has really helped me over the last couple of years too. So I appreciate the opportunity to learn from you all, because I have learned so much from you all. And I do appreciate everyone that's joined. I know health policy isn't as sexy as some of the other topics that we're talking about this week, but it is something that I'm very passionate about. And I have learned a lot over the last couple of years. The Cambia Sojourn Scholar Award allowed me a lot of space to grow my health policy, even finishing a graduate certificate in policy studies here at Clemson. And thank you, Marisette, for not holding it against me that I'm a Clemson alum, but I am also a USC alum. So I am a little bit of a house divided. So don't give me too much grief here. I'm on both sides of the fence. But anyhow, today we are going to talk about some health policy issues, and I have some slides I'll pull up here in just a second, but I do want to kind of ground us a little bit to say that there are three parts to this presentation. One is some of the hot topics, and these are, to me, very relevant to the serious illness group of patients, caregivers, health systems, legislators, because these are the things that we're going to be looking toward over the next several years, probably the next 5 to 10 years on some of them. And then we're going to shift and look at some federal legislation. Last year, when I was here, I was very fortunate to be able to share some of the federal legislation that was in the Senate, in the House, and I'm going to give you some updates on some of those more pertinent bills and legislations. And then we're going to shift again and come back down to the state level so that we can get a little more idea of what does the landscape looking like. And I encourage you to share, because the one thing I've learned about policy over the last few years is there's lots of people involved in some of these policy initiatives. Sometimes we know about it, sometimes we're broken. Just like our health systems sometimes are a bit fragmented, I think policy initiatives and grassroots somewhat gets fragmented too, and we lose track of who's doing what. So I encourage you to use the chat. I know Marisette's monitoring it for me, and I appreciate that. I have some attachments on various topics of the, some of the legislation that I'll put up in the chat for you for references, because I feel like you want to have some takeaways from this presentation so that you can use as language to share, things to watch for. So we'll continue to kind of monitor the chat, and I appreciate Marisette doing that for me. But let's kind of get started here. And we're going to do, that basic, I think you guys can see my screen pretty well, but let me go to the slide deck. We're going to start with just the basic health policy and advocacy. I think that we as nurses and people working in spaces like our social workers are very strong advocates, and we speak the same language so many times with a little bit of a different lens, but we also have our hearts in the right place to try to help our patients and caregivers. So one of the things that I mentioned just a second ago, these are 3 hot topics. We will actually take a little break between each of these so that we can have some Q&A. And I think that that'll be helpful for you to be able to say, hey, look, I've heard about this, or I want to know a little bit more about it. So we're going to start right out of the gate with a very interesting topic that I think is going to become more and more relevant to our spaces. And this is water insecurity. And then you're probably like, well, that's a little weird to start out with that. But I think what you're seeing and what you're going to see over these next years is a lot of work going to be done on water insecurity. And this is certainly a global problem, but I'm looking specifically at the US area. And, there's some really compelling data right now that's talking about our issues in the US related to water insecurity. And let me just throw this out. 2 million right now are without running water or basic indoor plumbing. That's kind of frightening to me when I think about that. And then we know that there's about 60 million drinking from systems that are out of compliance with the Safe Drinking Water Act of 1974. And one thing that I've learned about policy is these things can go clear back, right? Like we'll have a cornerstone policy that was initiated back in the 60s and 70s, and then we just add on to it over the years. It's not a matter of restructuring it, but the Safe Drinking Water Act of 1974 established guidelines related to the water systems, the infrastructures. And what we see here in the United States is that we've got a lot of these water systems are out of compliance of this act. And we also have private wells. So a lot of times the well water is not of high quality, and that can lead, from my perspectives, to some pretty significant health issues. I think we saw that in Flint, Michigan. We know there's some issues there, but this is just the start of, I believe, what we're going to have trouble with. We have underinvestment, and we also have regulatory abandonment. That's a key, that's kind of a phrase that's new maybe to some of you, is where we establish these regulations and we expect things to take place, but then we shift away from it, right? We move away from the regulatory guidelines. We don't have any kind of watchdog keeping an eye on it. So basically they become abandoned, and then we have a kind of a free flowing, oh, let's just do this and let's do this, and we're not following the guidelines. So we've had also a very interesting situation, which I think we're seeing on a lot of different topics, is the federal government's now shifted the responsibility of the watering system and the safe drinking water to the state and the local regions. And what that translates to is higher costs for the states, and it gets passed down to the consumer. So you're going to have patients who may say, well, our water bill's really high and they're having to restrict some of their water. They may not be using as much as they would for hygiene issues. And I think that's where we're going to see some health implications. Water is going to potentially become unaffordable for some of our lower income populations. And again, I think there was some literature too that showed the link between serious illness of mental health issues, and access to water. So we've got a problem there that we've got to be watching for. And then long-term issues include kidney failure, hepatitis, diabetes, and even cancer. So they're pretty substantial situation here when we start thinking about water security. So I would say that the White House, right, put out a global water security kind of a white paper, if you will, in June of 2022. And what they basically said is we've got 3 pillars here that we need to watch for. And that's WASH, that's an acronym because we all live in acronyms and we can't go without acronyms. WASH stands for water, accessibility, and safe drinking and hygiene. So it has to do not just with the flowing of water, but the wastewater too, and the hygiene issues that go along with it. Pillar number 2, they're talking about sustainability and how are we going to sustain ongoing water demands. And you can see from this image on the slide here, we have water supply stress index. And I know it's not surprising to see the west side of the US, the West Coast, really straining with some of the water because of their high heat temperatures, but they're going to have to be pulling water from someplace else. And that's going to come from the mid to the eastern coast that we're going to have to supply some of this water to them. And then the third is multilateral action. So what in this pillar number 3, the White House is saying, the Biden administration is saying, we're going to get everybody together, right? This is great from my perspective. Let's get all the key stakeholders at the same table to try to sort out this problem. And so those are what the White House is talking about with this action plan. It's not uncommon for the White House to put specific action plans out. It's actually a very common thing that gives and leads the direction of legislation and regulators and policymakers to know this is what the goal is. So what we have had is 2 legislative bills that have come out, the HR 3684 and HR 5376. And I'll send these slides out because these are links. You can see they're linked to the bills so that you can take a look at them. They're not horrible. Basically, what these 2 are developing infrastructure, right? Infrastructure Investment and Job Act was the HR 3684. And in that particular one, it came public law, but it's a $55 million investment that included some of our water structures that need to be built, right? Some of our water infrastructure that needs to be redesigned or redone, basically, because we're aging out. And then 5376 is the Inflammation Reduction Act. This is a very, very popular one. A lot of things fell under that particular Inflammation Reduction Act. And you're going to hear me say that several times as we look at some of these hot topics. Because in that one, and it became public law too, we've got $550 million for domestic water programs. So that's a very strong investment in water insecurity. So you can see why I think this is a very hot topic. Now, I didn't put the hot topics in order of what I think is a priority. I'm just listing them out. But you can see that the federal government saying we're going to invest a lot of money in our water. And then we also have $4 million for drought relief. And that's going to look, I don't really think $4 million is a lot when you start thinking about the drought issues, but it's a start. And then they did earmark 12.5 million for drought relief in our Native American tribal lands. So we're keeping an eye on this. Now, when I think about the impact of serious illness, I mentioned mental health, I mentioned cancer, I mentioned kidney disease, I mentioned hepatitis, but I also think that we as a CSI team and those that are on the call is what other things can you consider may be a problem if we're not even asking the patients the questions about, do you have access to running water? Do you have indoor plumbing? We would think automatically at this point in our industrialized country, we would have all these things, but just be aware that is not necessarily the case. And I know from our EHR here, we have the social determinants of health, and we do ask some of those questions. But I think as clinicians and folks working in this space, we need to be more intentional, but be sensitive about how we ask those questions, because we don't want to harm anybody by asking the question and making them feel like they're not doing what they need to do. But I do believe that it is important for us to be aware of what is happening in the world of water insecurities, and being also using our amazing social workers to say, okay, I've got a patient who's telling me they're running water's looking brown, right? Like, what do I do? Right? Where do I go? How do I help this patient? So I encourage you to think about this from a perspective of working with populations, and never assume that the patient has access to safe water, safe drinking water, hygiene, indoor plumbing, and where are we going to go with this? But it is good to know that the federal government and the legislation is working toward this. I'm not sure what the state here in South Carolina is doing related to water securities or insecurities. I did mention that the federal government is kind of pushing that down to the state and the local level. So we want to kind of keep an eye out on what the states might be doing with this, and certainly realizing that we look to other states around us to learn on policy initiatives and then kind of claim it and modify it to make it look like our own. So we'll look to our partners in North Carolina, Georgia, Tennessee to see how they're handling water insecurities. We certainly aren't in a huge area of water insecurity, but people on the West Coast are going to be looking for us to supply water for them. So we could end up with some problems here if we're not very, if we're not aware. So I'm going to move on to that's topic number one, water insecurity. That's an easy in, right? Like getting you grounded here with the first topic. Welcome to put any comments in the chat as we go along, if you have thoughts about it. But let's take a look at topic number two. Medicare drug price negotiation program. And I'm going to tell you, I am so excited about this topic. I started listening to some of the conversations about it a year or so ago. I had lots of great podcasts. I don't know how familiar you all are about this particular negotiation program, but it was because of the Biden administration that this even got initiated. So as a clinician, I can tell you, I fight all the time with the cost of medicines, right? Like I want to prescribe this, but it's going to cost $100 a pill, or I want to prescribe this and I can't get it because it's not within the budget of our patients. Because you think Medicare, automatically we're talking about those patients who are 65 and older, and the majority of them are on some limited incomes. And they tell you they spend $300 or $400 a month in medications. I kind of cringe because I think that could be a 25% of their monthly income is designated to the medications they need. So what we have here is actually the first time in history that the government can now actually come to the table with our big pharmas and start talking about how can we do better with these costs related to the drugs. And I'll give you an example there. Here on the slide, you can see the first 10 Medicare Part D drugs selected for Medicare price negotiation. So that's what happened. There were 10 drugs that CMS came out and said, okay, we're going to bring the pharmaceutical companies, big pharma, here to the table, and let's negotiate on some of these prices because they're really astronomical. And I'll give you 3 drugs that they were talking about, because I think these are ones that you'll probably recognize. Eliquis, right? Eliquis, those of you who are on the call, Eliquis is a very common drug. We actually have 3.7 million people in the US on Eliquis, and Medicare is spending approximately $16 billion a year for that drug for the Medicare coverage. Now that means we only have, I mean, if you start doing the ratios, we're spending a ton of money on this particular drug. The next one is Xarelto. That's also a big cost. We're spending about $6 billion on that one. And then Januvia is another higher cost, that's $4 billion. So these are 3 of the 10 drugs that CMS said big pharmaceuticals need to come to the table and let's talk about this. And some of the
Well,
reasons for
Tracy,
yeah,
Tracy, I know you work with these drugs all the time, but if you can give us the Cliff Note version of what Eliquis and Januvia, what they're used for, okay?
absolutely, absolutely. Yeah, so I do. I live in this space all the time, so I apologize. But I see that even Laura's even mentioned that her mother takes Eliquis twice a day. So, these are blood thinning medicines. These are diabetic medicines, right? So the top 10 tend to fall in these groups where the majority of our patients are taking for blood thinning or blood clotting to prevent blood clotting. Huge, great drugs, right? Very the solid science between helping to control strokes, helping to keep any kind of cardiovascular events down. But I do think that the costs are astronomical, and these do not have any generics. So that was the other thing. That's one of the regulations here. One of the requirements for this selection of the 10 drugs is there was no available generics to be able to have an alternative. So what happened here, and this is like completely revolutionary that the CMS and the federal government would actually be negotiating prices. This is, again, I can't emphasize, this has never happened before, that we've actually been able to come to the table and negotiate pricing. What took place was CMS made the announcement. They came out with the first 10 drugs, and they said, okay, pharmaceutical companies, come to us and let's negotiate. And what they did was give them 3 options over a period of a year to come back and negotiate pricing. And of course, the big pharmaceutical companies are going to negotiate prices. They need to be able to gain back the money that they used as an investment for research and development. And I think we all respect that. We just want to have some transparency with these costs and some engagement with it. So when the call came out, the CMS said, okay, here's the 10 drugs. I'm going to give you 30 days, pharmaceutical companies. And I did make a note of some of the pharmaceutical companies. So, we're talking about Bristol Myers Squibb, right? That's a very common pharmaceutical. Merck, that's another very common pharmaceutical. Janssen, those are some of our bigger pharmaceutical companies that are. Bristol Myers does the Eliquis, just so you know, by the way. Those are they're not these tiny little pharmaceutical. These are big name pharmaceutical companies that are, I did not look up their stock on the index because I don't want to know how much their stock's trading for. It gives me an example of how wealthy they are and how much money they have. Anyway, so the big pharmaceuticals received this notice and then what was to happen was within 30 days of this notification, the pharmaceutical companies would send back, yes, we're going to come to the table and a counter offer. And believe it or not, all of the pharmaceutical companies that were in these 10 Medicare drug negotiations came back with counter offers. I'm not surprised, are you? Like every single one of them said, okay, we're going to counter offer. And over the course of this year, right, like this is happening right now, we're going back and forth, right? CMS is going back and forth to these pharmaceutical companies negotiating these prices. And there's a kind of a really interesting legislation that it really forced the pharmaceuticals to come to the table. They couldn't opt out. And the reason why I say that is if they chose to opt out and not respond, then there was a sequence of events that would ultimately lead to the Department of Defense getting involved and penalizing these pharmaceutical companies for not negotiating with the CMS. So they did not leave any stone unturned here. They were really adamant that we were going to get this taken care of. So I'm really encouraged by this because I feel like we as clinicians and those of you who are actually maybe even helping your parents pay for some of these medications are going to see the effect of this and see the benefit. I put on the slide too that part of this Inflammation Reduction Act, you heard me talking about this just a few minutes ago with the water insecurities. This is what that came in. It was packaged under there. A lot of times these legislations have multiple arms. The policies have multiple arms, and it's like a huge moving project that you just want to kind of get caught and swept up in, because you can get things through when you have a big package like this. On the slide, you can see this actual legislation capped the cost of insulin to $35 for the seniors for a bottle of insulin. And I think about that from a couple years ago. I had to write insulin for patients, and I was helping them get it from Canada, because our bottles of insulin were $100. And the same exact manufacturer and the same pharmaceutical company was in Canada, was like $30. So it took us, I mean, I was doing that 7 years ago, but it has taken us a while to get here. But now the cap on insulin has taken place, and it's $35 for seniors. And then in 2025, another provision under this Inflammation Reduction Act is going to cap the beneficiary's Medicare Part D out-of-pocket cost to $2,000 a year. What an amazing idea, right? Let's not have our senior citizens pay so much in, so much money in their medications that we're actually, kind of taking away from their opportunities to. I think about it, they can't go on vacations, they can't afford it because they have to buy their medicines all day long. So as you guys are thinking about working with these patients, I encourage you to share with them. We are in the process, our federal government is in the process of the negotiation stages. So realize this was just the first year of 10. And they're in negotiations right now. The next year it's going to be 15 drugs. And there's a lot of speculation. What's going to be the next 15? Like, what are going to be our next 15 drugs? And we won't know right now. There are a couple of those drugs that are very cancer specific, may not be affecting a large portion of the Medicare beneficiaries, but it's costing a lot of money for those. So we really do. I think this is just like you said, Lavania, this is fantastic news. I'm so excited to see what's going to happen with this. And I'm watching it very closely and encouraging my patients. There may be an end in sight with the costs that you're having to absorb for your medications. So topic 2, and I do think that's a pretty good one to follow along on, and I'll keep you posted on it. Yeah, I agree, Maricette. I'm totally psyched about it, to be honest with you. So we move on to topic number 3, and this is telehealth, right? This is another really big area that folks are watching. Lots and lots of discussions about telehealth. And this goes back to when we had COVID-19. We had the Public Health Emergency Declaration, Section 319. And what we had was so many kind of restrictions that were in place for telehealth were lifted, right? They were lifted. They were said, you can do what you need to do to take care of these patients. Because we can't see them in person, we want to reduce the exposures. So it was part of that public health crisis we had with COVID-19. And so over the year, though, this last year, we know that COVID-19 numbers have decreased. And certain things that were put in place for the public health emergency have now been lifted, right? It's gone back to what the original policy has said, with the exception of some of the telemedicine flexibilities. And I would say that in 2024, 2025, these next 2 years, we're going to see, well, basically this year for sure, we're going to see a lot of conversation about what do we do with telehealth now, right? What do we do with it? It worked really well. I know folks love it, but then we also had such a huge pendulum swing that Amazon started doing telehealth medicine appointments. I'm like, wait a minute, wait, hold on here. We might have gone a little too far the other way with this, gang. And that's what's happening, right? Like that's what they're looking at to say, what is going to be the right approach for telehealth right now? And what I put up there for you on the left-hand side is the Dateline series of when there's ends of flexibility for telemedicine. This is why this is such a hot topic right now, because these deadlines are coming up, right? November 11th, 2024, we have an end to telemedicine flexibilities for prescribing controlled substances. Right now, we can prescribe controlled substances to patients if we have never met them before, and we can continue to prescribe beyond that. This one, what will happen is you'll have to see that person in, like, face to face in order to be able to prescribe the controlled substance once this flexibility ends. Now, that may make a lot of sense for some of us, but I will tell you, in the behavioral health world, they're really opposed to having this into the telemedicine flexibilities, because we have such limited such limited mental health folks and behavioral health that are prescribing, that they may be 60, 70, 80 miles away from the patient and be able to prescribe them through the telehealth platform. But if we end this flexibility, then the patient's going to, who takes on the burden of responsibility to get to the mental health is the patient. And the reason why we have it this way is because we don't have enough mental health folks in these communities. So that is this kind of area, right? Like, this area of telehealth and what this is going to look like in the future is, like I said, a really hot topic. Some of the things that are being questions that we're addressing here is should telehealth be a permanent expansion, right? Should we have a permanent expansion for Medicare beneficiaries? Because right now, we know how we as a clinician, I don't know if you guys are aware so much, and there might be a few clinicians on the call here, but there's some very specific documentation that we have to have in our medical records so that we can bill accordingly and that we're in compliance with the guidelines. That's administrative kind of tanglement that it takes us some time. We've got templates, certainly, but it does take some time to be able to do that. So they're saying, well, what is the permanent benefit of telehealth look like in Medicare? The second thing is, what do we do with these phone calls? And let me explain what I mean by that is, I'm on a virtual call with a patient. We're right in the middle of like a video like this, and then their system shuts down or their connectivity is really bad, because we have all kinds of connectivity issues here still as a problem. And that then we revert back to just a telephone call. That's one scenario. How does that get billed? How does that look? Right now, we can continue billing it as a virtual visit because we initiated the virtual visit. But what about these patients who have no Wi-Fi? Like, I honestly, some of my 80-year-olds don't even know how that works. So it's a problem for them. There's no way, but they're happy to get on a phone call with you. They're delighted to talk to you on the phone, and you're spending just as much time explaining, navigating, assessing as you would if you were on a virtual. What does the video change in the middle of your conversation? And that's one of the questions they're asking. What do we do with these telephone calls? Because they are critical to some of our rural communities to be able to access their caregivers. And then what regulations should be placed on in-office visits, right? Should we have, like, every third visit should be in office and not telehealth? Or is it every sixth? We don't know. We've not even looked at that or studied any of that to at this point, because no one predicted the pandemics. How will we know what this is going to look like? And then the telehealth payment models, right? We have got all kinds of payment models related to telehealth. And I will send out an attachment of a Senate committee hearing where some folks from Harvard, some really smart people from Harvard, came forward to the Senate committee and addressed some of these things and shared with the Senate, this is the work that we've been doing. This is what we've seen being beneficial. They did say, in the Senate hearing, that these researchers and legislators, or excuse me, the researchers at Harvard were saying, you need to continue telehealth, but look at it through the lens of quality. And I'll quote one of the little places where it said, telehealth works to help identify stroke, right? Critical time, critical points, but it's not that beneficial to manage a cold. I was like, well, that's interesting, right? I thought that was interesting. They were pointing to that, and they had done the numbers to show that it really is not that beneficial for kind of colds. I was like, okay, well, if the numbers are the numbers, we do work from that. These researchers also encouraged Congress to avoid a one-size-fit-all telehealth policy. And I agree with that. One size fit all does not work in across the rural communities, the urban settings. I think that we have to be very, very careful that we're not trying to say, well, this is the way it's going to be, and it is not going to apply to our settings. It's not going to work. I just gave you an example. Some of our seriously ill patients cannot physically get into the office, or they don't have Wi-Fi. So the telephone visit is got to be a way that we can at least connect with them. And then the last thing they talked about was limit the administrative burden. And I mentioned to you about how the charting has to be, the documentation that has to go into it. And that's just on my end. I know from our billing per people, the folks on that side, there's a lot of work that they have to do for telehealth. And so our researchers from Harvard are saying to Congress, cut some of that out, right? Cut some of that out, that burden does not need to fall, and get rid of some of that. So again, really, really hot topic. We're going to be seeing lots more coming out from it. What is it going to look like? I know from a fact, I do not want it to go away, right? I do not want it to go away because I have patients who physically cannot get into the office to see me. But I'm very curious to see what our federal government is going to do. And as you can see, we've got deadlines coming up, right? They're coming up, so they're going to have to make some pretty hefty decisions pretty quickly. So the next one you can see on here is Medicaid unwinding. And I would love to know in the chat, if for those of you that can get to the chat, how many of you are familiar with this topic of Medicaid unwinding? I'll give you a few minutes to type in what your exposure experience has been with it while I share a little bit about the history to why we've come to this. And again, it goes back to the COVID pandemic. We were typically the way Medicaid works is that every year, every other year, you have to re-enroll. You have to submit information, you have to submit paperwork that shows you're still eligible for Medicaid. When the COVID system hit, our DHEC and all the other, state level health system just paused, right? They had their hands full with reporting COVID. So the federal government and the states coming together said, okay, we are not going to have these participants in Medicare have to re-enroll. We're just going to hold it. We're going to give them access to their services for Medicaid, and we won't have them go through that all the time. And that worked really well, right? Because that meant we had uninterrupted coverage for some of our Medicaid populations, continuous enrollment that allowed for them to access whatever they need, right? The waivers, none of that was taken away. We held that. And during COVID, it worked really well. But now those waivers and that ability to just continuously be enrolled in Medicaid ended in April of last year. And what that meant was that everybody who was on Medicaid needed to reapply for Medicaid. And that has turned into be quite a disaster, not just for the state of South Carolina, but across the US. Lots of people who were on Medicaid didn't know that they were supposed to re-enroll their Medicaid. Either they changed locations. A lot of people had housing shifts during COVID. Their mailers did not transfer. And so we have a ton of people that did not re-enroll. And there was time frames where they said, okay, we'll give you 4 more months. We'll give you 3 more months, trying to get folks back on Medicaid. And then there was just a deadline where you're like, you dropped, right? We've dropped the services now. You no longer have Medicaid. And right now, there's lots of data that's coming out to show how this is looking from state to state. So I popped on there yesterday and took a look right now. And as of January 2024 in South Carolina, we had 84,000 beneficiaries in South Carolina that were due for renewal. Now, Medicaid includes our pediatrics, or disability, but it also can be those that are over 65 with low income. It is a low income driven service and disability service, but 84,000 people in the state of South Carolina have not re-enrolled with Medicaid. And I can imagine the reasons. They're probably vast, right? From not realizing, not having access. I don't know if you guys have ever looked at the Medicaid enrollment process. It is not easy. It is not an easy system to navigate. And then we had so basically we've had about a 9% drop in Medicaid and re-enrollment. Now, what does that mean for us? For clinicians, for our health systems, I think you can see the implications. If you don't have your Medicaid, you're not going to get your SNAP, which is your food access. You're not going to get access to health insurance because you're going to be denied because you no longer have the coverage. And I was looking to see how long it was taking to get folks reinstated. Originally, it was about 30 to 60 days, but I think that has now increased because of just the timing. We've shifted attentions, and there was a time period when it was first going to be dropped that people were getting turned around quicker for re-enrollment, but that's now taking longer. So I think this is going to be an ongoing problem, and everybody's watching it. We don't have the solutions yet. We have not figured out what the solutions are going to be. It is something that that we as South Carolinians have to be aware that we have a fairly high portion of Medicaid enrollees here in our state. And so, again, I go back to, I hate to kind of shift responsibility, not really responsibility, but I know our social workers are working like crazy to help keep these folks enrolled. But I think as clinicians, we need to be aware of it and also serve as a platform to make sure our patients are getting access to the Medicaid that they need. So that's another kind of hot topic there.
Yeah, so Tracy, just wanted to just pop in for a minute to say that in South Carolina, the DHHS contracts with SC Thrive to do these redeterminations and applications for SNAP benefits, foster care stuff, and Medicaid. And they have, I'm telling you, been working around the clock. So for those of you, there is a number, they've got a call center where those individuals are plugged into the Medicaid system to be able to get those applications expedited. And so that I do know a lot about that. My husband works for SC Thrive, and I know the executive director well, Trisha. So definitely something that I absolutely believe could be disastrous for our seriously ill patients who need their medicines, as we were just talking about medicines. And then also when you talk about not only medicines, but Medicare, emergency room visits. Many of these are folks that are being seen through the federally qualified healthcare centers who get those dollars as well. So for our underserved and under-resourced families, this is a huge, huge area. So.
Thank you, Marisette. I appreciate you adding to that. And I mean, I just echo the same thing with you. And I know folks are working very hard in our state, probably just as hard in North Carolina and across the systems. It was a great idea initially because we had only so many resources to manage COVID, but I don't think anybody anticipated this outcome of holding or pausing eligibility re-enrollment. And the conundrum and the catastrophes that we're seeing now post-COVID related to Medicaid. The other thing that just kind of leads right in, and this is one of the areas that I'm going to be working on when I'm in DC, is the dual eligible beneficiaries. So let me unpack that in case folks aren't as familiar with it. People who are dual eligible mean that they have the ability to have Medicare and Medicaid. And remember, one is state given, driven Medicaid, and one is federal Medicare. You would think they would talk to each other more. And we even have a federal duals office that are trying to coordinate services. But we have some major breaks in these systems. And I included there on the slide that about $36,000 a year is spent on a dual eligible beneficiary. And the reason for this is these folks are usually really ill, right? These are going to fall into our serious illness group of individuals. They also have some pretty hefty social drivers, social determinants of health. So we're looking at poverty, low income individuals. So when you think about how much money we are needing to spend to help sustain them, it's a big amount, but I don't think it's not hitting the areas that we need. And let me give you an example. In clinical practice, I have patients who have they're called duals, right? They have Medicare and Medicaid. And I might write a prescription, for example, for a nebulizer, right? Simple piece of equipment for a pulmonary patient. Well, Medicare is not going to pay for it because Medicaid's supposed to pay for it. Medicaid's not paying for it because it falls under Medicare. Like, who is supposed to pay for this piece of equipment? Nobody seems to know. And who is left without the needed equipment is the patient. So I think that this is a real problem, and we continue to find gaps, right? Wheelchairs. I don't know how many of you deal with wheelchairs or powerized wheelchairs. It is a nightmare. We know for a fact that powerized wheelchairs will not be picked up by Medicare. So it goes to Medicaid. Medicaid denies it. They'll deny it 2 or 3 times before it goes back to Medicare. And I was like, in the meantime, my patient or patients that are in need of these mobility devices wait 6 months to a year just to get the paperwork straightened out. Who's going to pick this up? So there's got to be some restructuring of this. And what they're suggesting is that we have kind of a structure here. Oops, back up. Let me back up here. We have something called independent enrollment broker model. And basically what happens here at the state level, for example, South Carolina, we have these independent brokers who are working with Medicaid individuals to say, here's a Medicare Advantage plan, a Medicaid Advantage plan that will meet those needs that you have, but they're not necessarily looking at it from the dual benefit, right? They're just looking at it from a singular silo of Medicare and Medicaid. So what they're suggesting is, because we have this kind of independent enrollment broker at the state level, we should create the same kind of structure at the federal and the state level so that we can see both ends of the Medicare Medicaid conundrum. I don't disagree with that. I don't know that they really know what that's going to look like and how that's going to work. But ultimately, we got to start doing some major renovations for this dual eligible program, because we've got people who are just not getting what they need. And a lot of times these folks are picking certain Medicare Advantage plans or Medicaid Advantage plans because they see they're going to get a food card, right? And I agree, right? I've got patients who say, I get $100 a month for medications, but at the same time, they've enrolled with the system and they've dropped other benefits that they weren't aware of, right? They see the immediate need of food, but now they have to pay $100 or something, something going to be off about it. Most of the time their medicines are covered because they have Medicaid, but other services and other equipment needs are not. So it'll be really interesting to see what's going to happen right now related to the dual eligibles. Everybody's aware it's a mess. And I'll be able to hopefully give you an update next year when I've been up there for a while to see what is the pulse when it comes to the dual eligible beneficiaries. And then we have one very hot topic here in South Carolina, as well as North Carolina. These are our partnering hospital at home. Again, I'm curious how many of you are familiar with the hospital at home system. We are a little behind the time on this legislation, and it's because we had some regulation in our language that did not allow for a hospital at home to take place. So basically CMS, the Center for Medicare Services, launched this kind of what they call acute hospital care at home during COVID, because we knew that patients really didn't want to go to the hospital. We need to keep them out of the hospital. So we CMS lifted some of the regulations that required care to be rendered in a hospital setting that could now be rendered in a home, which also meant like all what you think about a hospital, right? 24 nursing care, care given at home. Our legislation, again, North Carolina put a bear. We didn't know it, right? At the time, we had some language in our legislation that didn't allow this. Well, now the language has been adjusted and we can create and have hospital at home. Now, some of you are on the call probably familiar with this because there are institutions, right? Prisma. We have 8 locations that Prisma Health now that have the hospital home. There are 4 locations with Roper St. Francis, and then there are 7 locations with MUSC. So we are now kind of growing this. I'm very excited about the fact that we can deliver this hospital home. And the North Carolina, like I said, had some similar issues in their language and licensing barriers that prevented hospital home. And I believe they got through that May or June of last year and have lifted that language too. But I think for serious illness populations, this is a perfect way to receive care. They want to be at home. They want to have their care rendered at home. So this is a really exciting kind of situation to follow. I'm very interested to know basically what the funding streams are going to look like and how is this going to basically lay out. We have an extension for this through December 31st of 2024. What's going to happen after that? Is CMS going to continue allowing the hospital home? Still more of that to be unknown. But good to know that some of you are familiar with the hospital home system, but it is a very exciting program for some of our seriously ill patients. So this is our break point, right? This is where we get to think about Charlie Brown and we say, okay, yeah, I learned from yesterday, I live for today, I look to tomorrow, but I rest this afternoon. You gotta love Charlie Brown. And this is where I told you we'd have just like a pause. Kind of shift your brain a little bit. If you have questions about some of these hot topics that I covered, I briefly talked about them. I did not cover all of them in depth, and I know that would be way too much for you. But if you have questions, feel free to put them in the chat. And I'm going to pause for a moment and take a drink of water. And then if anything shows up, we can address it.
I just wanted to make a comment about the telehealth piece that it is a real concern. I absolutely agree with you that one size does not fit all. I think there needs to be, based on geography, where telehealth makes sense. I was in Portland last week and we were talking about health equity issues and end of life care for hospice and palliative care. And in the wintertime, they can't get to people. They said, we cannot get to individuals in these rural outlying areas. Summertime we can, but wintertime we can't get to these folks. And so we have a fair number of rural populations across the country and even in South Carolina and North Carolina, you know, but then you also have the connectivity issues as well. So I think we have to look at some innovative ways to get to people. And it may mean that we've got to look at the workforce who actually is equipped to get to certain people in some situations. So definitely don't want to limit access to folks. The other thing that you mentioned too, Tracy, was about telephone. And of course, for the hospice industry, the nurses could count telephone conversations during COVID, but social work and chaplain could not really count those. So when you look at the team approach for serious illness care and who is able to get credit for those communications and the time it does take to coordinate care via the phone, there needs to be a billing mechanism to capture that, for our APRN nurses, our physicians, in some way to capture some of that, the billing for that for some of the other team members as well. So I think that there's a thing here from Lavanya, who has a dual capacity. She works for SC Thrive, but she also is a social work student. So great for that. So Nina is asking who provides the care in the home because she's not familiar with the hospital at home concept.
Nine, I think that's a great question.
Lavanya,
Realize that
Lavanya says she's not familiar with
hello?
that as well. Lavanya.
Oh, Levon. Okay.
Lavanya and
Can you
Nina.
guys hear me? Oh, okay. The hospital home, my internet is a little unstable, so I apologize here. If you can hear me okay. The
We
idea
can,
is that it is
we can hear
replicated
you.
just as in the hospital. And I know there's some folks on here that are actually from Prisma, maybe even Roper St. Francis that can speak more to it. But the concept is that it is care that you would be getting in a hospital at home. So think about what you're getting in the hospital, you're getting in the home setting. So, you know, that's kind of the basic nuts and bolts of it, but that's the idea where, and I love the little kind of the acronym. It's the H with the @ sign H, right? That's what you'll see when you see hospital home. It'll look like, here, I'll put it in the chat box. Whoops. Oh, it's wanting to populate it the other way with some. There we go. Yeah, thank you. Thank you. There it is. So if you're seeing some of that, showing up, know that that's what they're referring to is hospital at home. So, well, great
I was,
conversation.
yeah, I
Yeah.
was going to check with Jenny because I know the case managers do a lot there with Prisma. So Jenny, I don't know if you want to add to that conversation about hospital at home, or Lori, either one of you.
So I am actually in the car driving to Greenville. Can y'all hear me okay?
Yeah, we can hear you.
Oh, awesome. Okay. Yeah, so I am not that close to hospital to home, but my understanding is they come and load, monitoring equipment, and that there are daily visits,
So Jenny, we lost you.
sometimes twice daily from a nurse, depending on what the patient actually needs, but the patient is monitored. Well, it's because I'm in Newberry.
All right, we're losing you a little bit, Jenny. So will pick this up at one of our CSI meetings and do a deep dive into it, since we know that it's still alive and well, and they may even do another extension. So you never know. But thank you, Jenny, for jumping in. We know that traveling from here to Greenville, there are some spots there where the internet probably comes in and out. So. All right, Tracy,
Yeah.
we'll
Oh,
let
and this
you.
is Valerie. I'm a social worker at Prisma Health.
Okay,
Yes, we
Valerie.
do hospital at home referrals lots of times, and a lot of it is patients that need like IV medications, while they're in the hospital. So the nurses do go out to the home, one to several times a day where they can, provide those IV medications for patients. And then you have doctors that are also monitoring. Some of it is a telehealth kind of thing. But it allows patients to go home instead of staying in the hospital for like 3 days of IV fluids when they can be at home getting that. So it's not a 24-hour, situation, but most patients that are pretty, ambulatory or have families that can help with them, it does allow them to get home for something, like that can be managed while they're there,
Mhm.
at home.
Hey,
Thank
it's
you,
Lori
Valerie.
Roper. So yes, all of the things. But there are very specific diagnoses that we're looking at for hospital at home. They also have to meet a certain criteria as, do they have a caregiver? What type of home environment they live in? Do they meet, different things to cover? So it's kind of like home health on steroids with a doctor intervention, several times a day, or, at least once a day, and then do some of those very specific tasks. One of the things that's kind of interesting to me is they do provide meals too, is covered with that. And I mean, the meals get delivered to their home just as if it was a, dietary delivering the meal there. So it is really an interesting concept, and I think would be a really interesting something for us to talk about in one of our regular meetings. And Jason Little is our program coordinator here at Roper. I'm sure that team would love to present, as well as the other programs. But it's definitely an interesting concept, but they still have to have basic supports. And so it's not for every patient. We're looking at doing some more hospital at home within some of our continuing care retirement communities that actually have built in already provided services that are privately paid for, and how do we keep them in those residents without admitting to the hospital, because we know, with some of our demented patients, that staying in their own environment is a great thing. And then also risk of other infection, and just really being able to care for people where they are at a higher level of care. So lots of interesting concepts around that. And it's really kind of a neat program that I think is going to live with us post-COVID.
Thank you, guys. I will tell you, I ran across a very interesting article that was talking about some of the hospital at home and this idea of twin data, because they're putting out these monitoring systems at the home, like heart EKGs and stuff like that. And how is that interfacing with our electronic health record to upload that information into the medical records, and this idea that we've got streams of data coming from these monitoring systems, and we have the EHR in a hospital, those would be downloading to back and forth. At the hospital home, it's not as clear. It's not happening as clearly as what we would think. And then we're transmitting private information and data across. This all has to do with artificial intelligence, of course, and the translation of information across unsecure systems. We had that with even COVID. And how do we communicate with the patient on a very HIPAA compliant? So I'm interested to see how this is going to look at the hospital home and the costs, right? I'm intrigued about what these costs are going to look like. So I know we could talk some more, but I want to shift real quickly and cover some of the federal stuff before we run out of our time. And I had hoped to keep this at under an hour, but I think we've got such rich conversations. I didn't want to halt anything, but this is some of the things I talked about last year, and I wanted to give you an update. This is the Comprehensive Care of Alzheimer's Act. This came out last year, and it was basically heard and read twice in the Senate. So this is how these streams go, right? Like a bill puts out, someone introduces it, and then it gets read. And then if there's consensus on it, it'll get referred to the Committee on Finance. Because even though we say, I want this legislation, well, who's going to fit the bill? And that's always the challenge, is where is the funding stream going to come from? And you can see over here, I have this little red thing that says prognosis 1%, and this comes from SkyOps Lab. Basically, we have this group of people kind of running algorithms to see how likely is this legislation to be approved. And it says 1%. And I think one of the things that the reason why they're coming up with this is we actually have in CMMI, the Center for Medicare and Medicaid Innovation, a demonstration project called the GUIDE model. And it is the guide and improved dementia experience model. And you can see we came up with a wonderful acronym. And I can send out some more information about the GUIDE model. I don't think anybody in the state of South Carolina joined the CMMI call to be a demonstration center, but we're looking at basically how can caregivers who are already taking care of these patients be part of the coordination of care and actually get funding for the work that they're doing, rather than paying private duty, which I don't know how many of you are familiar with private duty. My grandmother just went under private duty hospice. Hospice doesn't pay private duty, so we're paying about $28 an hour. I'm so thankful that those folks are there, but that's it's very expensive, and not everybody can afford stuff like that. And I also learned through the experience, long-term care policies sound fabulous, but they don't last forever. And her particular policy ends at 100 days. And so what happens after that? Long-term care policy only pays for a certain portion. So the GUIDE model is the demonstration project is going to last for some time. They're going to be collecting data along the way. It'll go clear up to 2030. And then we'll have a better idea. Is this a model that will actually be sustainable and beneficial and helpful for patients with Alzheimer's? So even though we're still kind of in that space with this Comprehensive Care for Alzheimer's Act, there is ongoing work right now with the GUIDE model, and we'll be able to follow that along a little bit more as it moves through. The next one, here's just
no, she's not here. I'm all alone.
I'm sorry, I think someone's talking. I didn't want to. The next one is basically, this is a picture of what the GUIDE model looks like. And it kind of walks people through, and it's an infograph, which is a little busy for an infograph, but the whole concept of Alzheimer's, and Laura was just talking about it, is to keep them out of the acute care facility if possible, because we know that exacerbates their dementia, and then they have some significant decline. So on the left, we have the common dementia care experience. On the right is the ideal experience under the guide model. So I think this is something to watch and follow through with CMMI. There'll be lots more information will come out, data reporting. They started the demonstration project with the identified folks who want to be part of it just the beginning of this year. So I don't know that we'll have much data this year, but maybe some starting next year and the following year. The next one is the SPARK Act, which is Specialty Physicians Advancing Rural Care Act. And this is something that's kind of personable to me because I want to see more primary care provided in rural communities. Now, this is specific for our physicians, and it's a loan repayment program to encourage specialty medicine physicians. Some of my folks down at MUSC did a study a year or so ago about the number of pulmonologists that we have in South Carolina, and it is drastically low. And we're in a lot of we're having a lot of problems. Say, for example, in Oconee County, we have one pulmonary practice for our entire county. So this is just examples. I mean, mental health, certainly, I think we're having lots of conversations about OBGYN deserts. I know that doesn't necessarily apply to serious illness, but not for nothing, but some of our grandparents are taking care of these newborns and these toddlers. So, I mean, it does kind of overlap in some ways. So this particular bill is going to help with a repayment. And as you can see down here, I'm just tracking this for you to know that it's been introduced. It's been now referred to the Committee of Health, Education, Labor, and Pensions so that we can start thinking about, you know, where is the funding going to come from? Because it's all about where the money is going to be. The next one is the Gerald's Law Act, and it basically was providing burial and funeral funds for certain veterans who die at home or in other settings while in receipt of hospice care that has been furnished by the VA. The VA has, as Marissette mentioned on Monday, there was a great presentation on the hospice benefits under the VA. This particular legislation is looking at supporting for the burial and funeral services. It is a little bit of it's surprising how much it costs to actually bury someone. Those of you who, I apologize if you've had to experience it, but it is not a, you're looking at a lot of money sometimes for funeral services. So this would help our veterans. And it's been referred to the Veterans Affairs as one thing you'll learn about policy. It'll take years to finally get it to the end point. So we're just kind of trugging along here, but we have referred it. So this is good. These last couple bills that I mentioned have been referred to the committees to figure out the funding streams. And then the Support Our Direct Care Workforce and Family Caregiving Act. This feels very similar to me to the guide model where we're trying to support caregivers. But this isn't necessarily just for Alzheimer's dementia. This is looking at serious illness and direct workforce. So that has also been referred to the Committee on Health, Education, Labor, and Pension. So we're moving along there. And then we have a resolution. I didn't know if you guys were familiar with this. You may have heard a resolution designating November 2023 as the National Hospice and Palliative Care Month. That went through Congress, was unanimously approved. It was not something that required funding. It was just saying, this is what we want to do. So in November, that is the month for National Hospice and Palliative Care. So I'm very happy that it's being kind of limelighted as a month to be aware, and that'll give us an opportunity here with South Carolina and North Carolina CSI to really push out some narratives and talk about certain things that we feel are important related to hospice and palliative care during the month of November. And then let's just shift to South Carolina State Legislative update. There's not a ton that I have found, but I know I'm probably missing some. One of the things that they were looking at is this legislative bill that impacts the certified medical assistants. And this basically means what they're trying to do is to allow physicians and physician assistants to delegate certain responsibilities to a certified medical assistant. I know that in practice, that happens all the time, but the legislation doesn't really allow it to be taking place. So we got to catch up. Our legislative bills have to catch up with our practice. And this is one area that they're looking at, and it'll probably go through without any problem. But I did want to let you know that it was one that was under review and moving along. And then there is a model about, it's called the AHEAD, right? I told you we live in acronyms. I can't remember any of them most of the time, but we know this is basically advancing all payer health equity approaches and development. This is hospital based, right? So what they're trying to do, and this is coordinated across the US, this isn't just South Carolina. There again, it's I feel like a lot of it's about care coordination, curbing costs, improving population health, but this is very hospital centric. And we're just kind of getting started on this. And I think, Marissa, this could be one of those topics that we do at one of our monthly meetings or one of our sessions to talk a little bit more about this particular model and how it's giving states incentives to create a more streamlined health system along our health care systems, right? Like Prisma, Bonsecore, Roper St. Francis, McLeod, all of our health systems in the state, and kind of coordinating the care across that so that we're not causing gaps in care. But this is just getting started. So I think we need to be on kind of watching for it and seeing what's happened. I give you a little bit of highlights there. And like I said, I'll send out the slides and some other attachments with it so that you'll have a chance to take a look at some of the more detailed that I really couldn't and didn't want to drag you through in this conversation today. So that is kind of the space that I've been working in the last few years in the hot topics and the federal and state legislation. I welcome any comments here. I'm just going to mute myself for a second.
I wonder, Tracy, and I think I saw this earlier this year. Have you heard of any extensions through the state legislature for APRNs and PAs in terms of telehealth scope of practice issues in terms of that area for South Carolina?
I think that topic is always on the forefront of scope of practice, period, right? Scope of practice in general. And how is that going to look for us? I think we're in that same space that we're trying to figure out what the federal government's going to do and what CMS is going to do, or what are we going to be able to continue having telehealth? I know our state and pretty much every state across the US only allow us to work within our boundaries of our state. So if I decided to go across the border and do telehealth, I wouldn't be able to. And I don't think there's a lot in that space right now that that we're looking at, because we just don't know if it's going to continue to be funded, right? If telehealth continues to be funded, then I'm sure we're going to have to start tackling some of the language in there.
Very good. Well, there is an endorsement in the chat about that health policy is sexy from Heather. So she's giving you the high praise and endorsement for an amazing overview and session. And I tell you, I rarely think about water security stuff because, you're thinking it is something that's in a third world country that we don't have water issues, but we do have them and so I absolutely appreciate you bringing up that point as well. So the floor is open for questions or for any other discussions that anyone may have. You guys, and definitely hearts all around on the screen for Tracy. I'm telling you, that is a daunting topic. And this was absolutely, Dr. Fasolino, we absolutely appreciate all the work you put into giving us such an amazing deep dive in terms of these hot topics. So yes. All right. Medicare and drugs. I just got my red, white, and blue card this year. And so, I'm diving into all of these things related to what they're going to pay for, what they're not going to pay for, and particularly with the ACOs, that kind of stuff. Which plan do you choose? A lot for our seniors to deal with. Most days I don't think of myself as a senior, but I guess, Medicare regards me as a senior since I have a red, white, and blue card now. So.
I didn't really get into some of the discussions about the Medicare Advantage plans, but I'm going to tell you that's going to be the next kind of hit list is lots of folks kind of stabbing away at those Medicare Advantage plans, how they offered so much and they're not delivering what they said they were going to deliver. So I am very, very aware of the gaps in the care that was going to be provided under a Medicare Advantage plan that has not. So I'm I'll be watching that one too, for sure.
Yeah, yep, yeah. Very good. Well, Lori says every time she gets a notification from the AARP people, she's looking at that. So, well, thank you guys so much. And Tracy, once again, our heartfelt appreciation for your presentation today. Thank you for doing that. And also has given us a few things that we'll be able to look at for some of our summer sessions. As you guys know, we are not going to have our monthly meeting this month, as we have taken the time to get with each other each day this week for our virtual symposium. So we will definitely have our monthly sessions. Will start back in June. And so definitely email us if you have topics that come up, threads of things that come up during this week that we want to do further investigation around. So look at all of the accolades there in the chat for you, Dr. Tracy. So absolutely, you're a fan favorite. We appreciate you. Now, I want to remind you guys that we'll be back together in the morning at 8 o'clock. And tomorrow, our friends from North Carolina are going to talk with us about the new billing codes for caregiver support. So Heather and team over there from the North Carolina Serious Illness Coalition will be with us in the morning. As you know, caregivers are getting a lot more attention now, as they should. And so there are some new billing codes that primary care physicians can utilize in terms of training and supporting and educating caregivers, as well as some navigator codes now that are being used. I noticed that my own primary care physician now has a navigator in their office to talk with folks about, those social determinants. Are you having trouble getting your meds? Do you need a ramp? Et cetera, those kinds of things. So you definitely want to jump on tomorrow about what we can do to support our caregivers at 8 o'clock in the morning. And then we will be wrapping up the week on Friday with our talk on advanced care planning and clinicians and the faith perspective. What does that look like? So once again, we will be getting the slides and the recording to you after we wrap up the week. And special thanks to Jessica, who is handling that piece for us. And shout outs as well to our education committee, led by our fearless leader, Wilma Rice, for putting on an amazing week this week with all of these relevant topics. Everyone have a great rest of your day, and I look forward to seeing you in the morning at 8 o'clock. Bye-bye, guys.